Welcome to Prescribed by Dr. Nathan Goodyear, where integrative oncology meets holistic healing. This podcast is your home for the latest in innovation, exploration, and elevation in all areas of integrative oncology, medicine, health, wellness, and beyond. Join me and a host of other innovators as we go from practicing to prescribing. Your daily dose of wellness begins now. All right, welcome to another podcast here. Of course, I am with the innovator and the origin of the name, Dr. Williams of the Williams Cancer Institute. Dr. Williams, thanks for joining us again on the podcast where we really kind of go deep and we kind of go geeky on the science as it relates to innovation.
Yeah, exactly. Thank you, Nathan. Appreciate it.
So I get a lot of questions from patients, and I'm always amazed, Jason, at the level of knowledge of our patients. Mm-hmm. I mean, they are informed and then some. But the question that I've heard a few times is why the combined intratumoral ablation and intratumoral immunotherapy approach? So they recognize that people are talking about ablation intratumorally. They're recognizing that people are focusing on immunotherapy, trying to deliver it better, so going to the tumor.
Yeah.
But they're going, why is the Williams Cancer Institute the only area that has thought about combining these together? So give us some insight to your mindset that kind of brought together this combination.
Sure. Yeah. Yeah. And I think, one of the things that you can look at it is, an ablative technique to destroy cancer in an immune stimulating way is just another immunotherapy option. It's a way to kind of start the fire going, right, and get things going. And clearly, there's lots of ablation technologies and, microwave, radio frequency. Those I would relegate to old technologies that I don't really think we have a purpose for. I mean, I really don't ever use I have the systems, right? I don't use microwave. I don't use radio frequency ablation. I do occasionally use cryoablation. I'd say pulse electric field certainly is now, the more dominant technique. I think we feel comfortable that, you're ablating in a immune stimulating way more consistently than any others. So we kind of lean towards that. But, and then you inject those drugs with that. So you're starting this process saying, okay, here's dead pieces of cancer. Here's these signals that you should attack it. And then we're going to further that with other pharmacological agents that are saying, hey, attack this. So we're just broadening that, building off of that ablative technology. Now, the question is, can we do it without ablative technologies? And, and we can. I mean, that is possible as well. I mean, there are things that you would say might function as like what we call lytic agents, so agents that you can put in there. I can think of several that we've worked with that are options. And then sometimes once you get the process going, maybe you don't need to keep doing ablation, right? You've got it going now. You can just like start injecting and push that along. But I do think that a lot of times in the initial parts, if possible, doing pulse field ablation is very helpful. And I think that that's something that should be done when you can.
Yeah, obviously there's synergy between the combination, but sometimes just because of maybe the organ involved, like the stomach, or there's some nearby vascularity, the ablation is not something that's amendable to safety, or which we see quite regularly is there's peritoneal carcinomatosis, and it's all a bunch of small nodules. And so you can't really go into it to ablate. And so you can kind of just, if you will, inject into the peritoneum immunotherapy.
Yeah. So there's cases that aren't really amendable to the ablative technologies. And but you can go at it with immunotherapies alone, right? You don't have to have that, but it's nice to have it when you can. And, I think that it makes the process easier. But yeah, there are certainly certain situations where, it's not possible or not warranted. So, we do it. But certainly you want to get drugs in the tumors or as close to the tumors as they can, because you want that action to happen there. You want the immune system to be attacking the cancer. And so you want, cancer, immunotherapy drugs, all to be in close proximity with immune cells coming there as well. So putting them all in close proximity, not just giving the drugs orally or intravenously. Now, certainly there's certain situations that you may need to balance out that you might do systemically along with it. But your primary focus, particularly when you're talking about trying to get a heavy like T cell insult or other very focused these effector responses, as we would call them, you want that at the tumor site. You don't want it all over the place. I mean, that's different. And so yeah, that's why you have to put the therapies kind of where the tumor's at. I mean, so
Yeah, just why more people haven't picked this up is beyond me. But
yeah,
there's a famous quote attributed to Mark Twain: "Synergy, the bonus that is achieved when things work together harmonally in a harmonious way."
yeah,
Spit that out 3 times. But people think, well, 1+1, so ablation plus immunotherapy equals 2.
yeah,
But actually, what we're really talking about here is 1+1 equals 10 or even 100. And it's some insight to the innovation of ideas that you really brought to the forefront of really the medical arena. But it's also the idea that's gone into purpose and now into practice. But what's really interesting about the combination here, Jason, is that in the arena of cancer, where everything seems to be about escalation, this approach actually is more really about de-escalation when we're talking about the systemic doses, the systemic delivery. It's actually by going to the tumor and activating the immune system, it's really a process of de-escalation.
yeah. I mean, you're putting more drugs, lower doses, but in the tumor, you're getting a lot less those off-target effects. I mean, the thing is that the effects are different depending on where the locations are, right? And so, that's why you need to deliver the drugs in that area. Um, so yeah, I mean, it's a key point. I mean, you really just can't treat cancer without trying to at least go directly at it. I mean, if you have sizable cancer to treat, I mean, now, some patients have microscopic disease and stuff like that. Okay, it's a different story. But if you've got a targetable tumor, then you should be targeting it.
I think that's the standard, and it should be the standard today, and I think it will be very soon.
Yeah.
So a lot of people would go, "Wait a second, I'm hearing you, but I thought we were winning this war on cancer," and that's what's being perpetuated out there. But it's interesting when you look at there's a 2021 a phase 1 study protocol that was published. They were talking about metastatic prostate cancer, not prostate, but pancreatic ductal. And they said there's no curative treatment option for patients with metastatic pancreatic ductal adenocarcinoma. And palliative chemotherapy regimens only moderately improve survival. Consequently, there is an urgent need for innovative and radically different treatment approaches.
Yeah.
That's 2021. How long have you and the Williams Cancer Institute been doing this?
Well, I mean, I've been ablating and injecting in tumors for over 20 years at least. I mean, in humans,
Yeah.
and in mice even more. So but
More
yeah. so yeah, but a long time. So and that's the thing that just seemed to make sense. I mean, we biopsy these tumors, so we're sticking a needle into it. Your biopsy is your first chance of treatment. People, the argument will be like, well, oh, you don't know it's cancer until the pathology comes up. Oh, okay, yeah, sort of. I mean, but I'll be honest with you, we can be about 90% sure. And we can inject some things that are okay. If it turns out it's not cancer, the patient's fortunate and it's not cancer, wouldn't be harmful, but would still be beneficial. Could be beneficial to other cancer patients, right? So, I mean, you could biopsy and you can inject ketorolac, you could inject, flu vaccine, you can inject vitamin C, you can inject ivermectin, you can all these type of things like that. if they come back and say, hey, oh, that wasn't cancer, oh well, no big deal, really, right? You didn't really cause any problems, and I'll be honest with you, that's gonna be the minority of patients, because the majority of patients, it's cancer, and we know it. Yeah, we know these up front. I mean, we're just sort of fooling ourselves. We're trying to make it. Oh yeah, we're going to biopsy because maybe this is not cancer. Ah, generally, when we're doing biopsy, we know. And generally, if I'm doing a biopsy of something that's not cancer, which happens, I mean, I would say that I'm like, this is not going to be cancer. I know, but I'm going to biopsy it because they want us to biopsy it. We're going to go ahead and do it. And in your breast cancer world, when you're audited by like the FDA and the stuff that regulates, they have the MQSA, Mammography Quality Standards Act type of thing. You have to have certifications and all that. One of the things that they analyze, they take a look at your biopsies, and if your biopsies are all 100% cancer, and you're not biopsying any benign disease, they would ding you. They would say that's not right. You should be biopsying people that don't have cancer. So now, I mean, so we do it. I mean, kind of. I mean, and again, people see a lot of, uh, fibroadenomas and things like that. They're not cancerous, and occasionally you'll get something that, yeah, it really looked like cancer and wasn't, but that's rare. But most of the time, and so and that means that we know that we should treat, and we know that we should be doing more things in the future. The biopsy will be the first start of treatment for patients, and that's what it should be. And hopefully, we can change that.
I mean, that idea right there alone is revolutionary, because most people, they get a biopsy and then you're looking, depending on where you are in the world, it could be weeks to months
Exactly
before treatment is initiated.
Mm-hmm.
And it's a missed opportunity.
Yeah.
In the arena of cancer, every missed opportunity.
Well, it's harming these patients because, now when you biopsied it and you inflamed it, you've started a process. And that's one of the things that they're showing, of course, is that the longer you wait for definitive treatment from the biopsy, the more likely this cancer is going to have spread. And that's because when you stick a needle in it, you might inflame it in a way that may make it want to spread faster. And so now you've started really a clock ticking on that. So you got to really, do something faster. So that's why we shouldn't be sticking needles in these tumors without doing something to them.
And that really has the potential to massively change the approach to DCIS in breast cancer. I mean, women all the time are getting mastectomies.
Right, yeah.
DCIS, but I mean, this has the ability to save breasts. I mean, think about it, because if we look at this from a perspective of testicular cancer, there would be an aggressive push to save the testicles. But for women, it's like, what? Take them off.
Yeah. No, and we shouldn't be operating on any of these patients anymore. We should just, identify the tumor, treat it directly, keep the patient intact. And, no matter what the stage, early, advanced, all of it, it should be immunologic, because that's what's going to offer you the protection. Cutting it out. I mean, obviously there's a situation, let's say a person diagnosed with colon cancer and it's obstructing. Okay, well, they're going to probably have to have surgery. There's, certain situations where those things are warranted. But for the most part, if you're dealing with something that is not causing mass effect problems in the area, and you can afford to then start injecting it, you could try to treat it and get rid of it that way, and not have to go to these aggressive surgeries and maiming the patients and removing body parts.
So let's go through some of the mechanisms of why the synergy of the combination. And the first is tumor antigen release and exposure, whereby with the ablation, we're getting the release of the tumor-associated antigens and the damage-associated molecular patterns you've talked about before. Yeah. But then the synergy with the immune system, optimizing the recognition and processing. Yeah. What's that kind of magic cocktail, if you will? And I've actually seen it referenced in the literature as the antigen flood.
Yeah. Well, so then, what's happening is you're getting those antigens, getting those signals, but then the cancer or the immune system, or in conjunction, has the ability to shut those signals off. Say, oh no, those this is okay. And so cancer, obviously, if it's there, it's going to try to suppress that immune response by having the checkpoints and things like that. So if you simultaneously block those signals that are going to shut off the immune response down the road, you keep that going and propagate it. Then also the others is that you have positive signals that you can send and say, hey, look, I'm giving you these pieces, and yet you should attack it. This is like extra signal. So you cover your bases by having a mix of all of it, so that you're giving the dead pieces, you're giving the signal. Okay, here's the stuff. This is what you should do. All right, here's your stimulus. Yes, you should really attack it. Oh, and then the things that want to shut it down, we're going to block those too. So,
I mean, it's novel and it makes perfect sense to us, but the more we talk about it, and clearly, there's lots of approaches to get this information out there, both in an educational standpoint, but also in a scientific standpoint. And I think that's going to be what really continues to elevate. But one of the things also too is patients say, well, I thought when you give therapeutics IV, all of it's reaching the tumor. So one of it is, so the second point here is modulation of the tumor microenvironment. And I think a lot of people fail to recognize the really dense matrix that exists, and also immune signaling that exists to actually buffer and keep systemic immunotherapy out. But the intratumoral ablation technique obviously disrupts that barrier.
yeah.
And also the intratumoral immunotherapy allows you to deliver it right to, so you're able to completely bypass that.
Yeah. I mean, again, it's like, hey, you want to get it there to the site. I mean, like, it's like, for example, you got this fires over in Los Angeles. And we could start infusing some water from New York. Eventually, it will get there. Right?
That's great. That's great. I don't know. It may not.
Well, it'd take a long time and take a lot of it, right? That's the problem. It takes a long time and a lot of it. The drugs are the same way. It takes a long time, a lot of it, a lot more drug, a lot more side effects, a lot more problems. And so, that's the issue when you're giving this thing far away, expecting it to get to the tumor. It's, it's not very much that's going to do that. And you're going to have to give so much. You're going to have toxicity issues. And that limits a lot of your uses of drugs. There's a lot of drugs that are good. They're like, oh, this drug, oh, it kills cancer. It does great. Oh, let's give it. No, it was toxic. Yeah, because you got to give so much. But when you're putting in a tumor, that's not the case.
So then, to use your analogy there, so the water coming from New York to LA, I think that's great, because then people go, well, what's the comparison or the analogy to the direct? Well, I think it's the planes dipping down into the Pacific Ocean, gathering
right on it,
going on and dropping it right on it.
Exactly. Yeah. I mean, that's what you got to target it directly. I mean, that's the thing. So,
it limits. So all this attack here directly, it limits all the limitations and really completely bypasses almost the pharmacokinetics of the liberation, absorption, distribution, metabolism, excretion. And so all of those limiting factors of when people take things orally or IV, we don't need to worry about them.
Yeah, exactly. And so much safer. It's just better all around, and so that's why, like, at least you've got to incorporate that. Now, I've obviously, we've been trying to get people to change this and push it, and I understand still, the systemic therapies are very embedded and ingrained in the system, and that's what's covered by insurance, and that we're having to kind of deal with that. So from my standpoint, I've come up with sort of what I would consider would be the compromise, and say, hey, look, do your systemic stuff, just keep it, but then let us inject.
Yeah,
let's make it better. I mean, let's improve it. You keep doing your stuff. Hopefully, then we're going to be able to get you off of that. Hopefully you have to use less of it, and we're going to make that better. But keep doing what you're doing. You're seeing your oncologist; they want to give you that. Let them do it. We'll jump on top of it, and we'll make it better. And that way, we're not offending them. Well, hopefully, we're not offending the oncologists. Now, it's funny if the oncologists say, "Oh no, but I'm not going to give you therapy if they're doing this stuff," because that makes no sense. But nonetheless, the oncologist is still doing their thing, and then we're slowly changing the system where we're not coming and say eliminate all that, now change this. let's have the transition.
Yeah, we're building a bridge. We're
Yeah.
building a bridge. It's ultimately about the patient and the outcome of the patient and the quality of life as they achieve that outcome. And it's really about partnering together and collaborating together to honestly make what the conventional oncologist has to do less negative and really help the patient more.
Yeah. Yeah. Exactly.
So the immune system gets activated because a lot of people think, well, we're destroying the entirety of the tumor. But really, what we're doing is we're destroying part of the tumor because we need these antigen-presenting cells to be recruited and activated within the environment to then activate the T cells. And that's a big misconception I see because most conventional, when they approach it with ablation,
Hmm.
whether that be radio frequency or whether that be the new histotripsy, they want to ablate all of it.
Yeah. Right. Right.
So
Which
talk about that combination and how that activates the immune system.
Yeah, and I think it's a very important point to know that, because originally this was our thought, and then, first logically you think, oh, there's a tumor there, we're going to stick a needle in it, we got to kill that whole thing.
Mhm.
I mean, that I understand it. It makes sense. That's what we did. That's what we always did. That's the standard of care now. I mean, you go anywhere, you go to MD Anderson, Sloan Kettering, any top cancer center, you get ablation. They're going to ablate you completely, and they're going to get a margin, and that's what's in. They're trained, and that's embedded, and we're trying to get them to see it differently, because we know, and I think I've mentioned before in one of the papers that we published out of Case Western, Alex Huang. I like was one of the advisors on the paper, and showing that when we ablated part of the tumor, that actually the residual that we left behind, that tumor began producing immune stimulating substances. The tumor did, oddly enough. It was sort of like damaged, and then it produces these immune stimulating substances, which then recruited the immune response more. Whereas if you ablated the entire tumor, you did not get that benefit. And as a matter of fact, you got the counter where you got healing growth factors, which supported regulatory immune cells, immune suppression, and cancer growth. So the way that ablation is done right now is harmful, and so it's unfortunate, but it is what it is, and we try to get people to understand this. It needs to be done a different way. That you partially ablate these tumors.
That brings me to mind of a phase 1 clinical trial published in 2016 on the preoperative single dose of ipilimumab and cryoablation in women with early stage breast cancer with comprehensive immune profiling. That's the name of the study. And what they found is that in the individual group of the ipilimumab and the cryoablation is that there was actually an increased Th2 cytokine, which tends to be more of a procarcinogenic immune
Yeah,
activation, but it was the combination.
yeah,
Only in the combination group did they see the Th1 cytokine activation, which is more of an anti-cancer, showing that really almost each one individually could be bad, but yet the two together
hmm
is really, really good.
yeah, and obviously you can get away with ablating the entire tumor. Sometimes it works, right? And you can do that, and sometimes you don't get enough suppression. And certainly, you add immunotherapy agents to it, you can overcome that somewhat. So, but we know that if we want to maximize this, and that's why I think the pulse electric field is a good technology, because in general, at least the system that we use ablate such a small area that it would be almost impossible for us to ablate an entire tumor. I mean, I know that the doctors in the U.S. who are using pulse electric field, they're trying to do this. They're making the. I mean, that's why they're not. That's why they don't like the technology, because it's so hard to do it. And the company, I think, is making a mistake, or they're looking to see how can we maximize this. How can we get bigger ablations? There's another competitor company that has a system out that has bigger ablations, and maybe pulse field is forgiving enough that you could do bigger ablations with it, and you don't have the issues that you have with cryo, because the technology is different. But the nice thing is that the technology makes it hard for people to get overzealous, and that makes it immune stimulating. And I guess we'll have to see on the bigger volumes.
So ultimately, the impact here is the abscopal immune response. And it's interesting that that word, it's two parts. It's ab, which means away from, and scopus, meaning target. So it's away from the target. First described in the radiation literature, 1953, by Dr. R. H. Mole. And really, because of the single approach of radiation, it was a very weak and rare observation. But it's really the target aspect of the ablation here, particularly the PEF, and the combination of the immune therapy in proximity. And understand, too, the published literature out there in the primary and the clinical world, that is human trials, though they're limited, it's one immunotherapeutic.
Mm-hmm.
What we're doing is creating a lot of new antigens for the immune system to respond to, and a lot of targeted immunoactivating agents all in the same mix. So it's not just a magic cocktail, it is a souped up
Yeah.
magic cocktail.
Yeah. Well, for me, on my patients that I treat on regular situation, we're commonly using 12 drugs at each treatment.
Right.
And so, and that's kind of what we found that works really well in most patients and doesn't cause, a huge amount of problems. And so that's kind of what we find. Obviously we tailor and adjust these and there's different situations and depending on, what's going on with the patient. But yeah, when you're limited to mainly PD1, CTLA4, technically we have LAG3 approved. Yeah, a lot of limitation. I mean, you could also expand out like IL-15. That agents approved. That would be a great one. But start thinking the expense. I mean, like Yervoy, 35,000 a dose. IL-15, 38,000 a dose. People want that. You start getting like those are super expensive. But yeah, we found I think a right combination that works really well. I think in the future. As we get more and more patients, more and more follow up, we'll be able to kind of publish this and show, okay, hey, this is the formula that we see that works well for the majority of patients. Is it the definitive cure for cancer? Not, maybe not. I mean, but will it cure probably a lot of patients? I would say yes.
Well, the important point there on that is there was a 2004 article, and check out the references in this podcast show notes because it'll be there. But where they were looking at the overall impact on chemotherapy with metastatic solid tumors, and they actually found only a 2.4 month increase in overall survival. Now that was 2004, but they were doing roughly a 20 year review. And so when you're talking about what is considered, quote unquote, one of the pillars of standard of care, if we're extending that 2.4 to say 8 months, but here we're actually doing much longer, it really begins to take something from a acute situation where they're just trying to be palliative in many ways, trying to slow down the progression of the disease, to really it becomes one of more chronic. Now, as it moves chronic, there can actually be a targeted move to actually regress it.
Yeah.
So it's a very different concept because if somebody is diagnosed with cancer and then 30 years, stage 4 cancer, and then 30 years later, maybe the tumor is almost gone, but yet the patient's maintained the quality of life through that treatment.
Mm-hmm.
That seems like a win.
Yeah. Well, I think where we're going to find the real definitive treatment, which we're already working on, is and again, it's different for different patients, but for some patients, you're doing ablation, you're recruiting that initial heavy attack, T cell, B cell effector type attack, and then you're finishing it off with this myeloid attack, which is like, so it's kind of like imagine a war, and you got your main big targets, and you come in with like your Air Force and stuff like that, and you blow those up. But now you just got like a few little small stragglers in there, and then you send your ground troops in, and that's your myeloid people, right? That's they're like the ground troops coming, going hand to hand combat on these people on the cancer and killing it. They don't go with this aggressive blow up. That's why they don't really cause autoimmunity. They're like this direct attack, and we know now how to push that response. And so that's the direction where, I think we will see the ultimate cure for cancer with that combination, and that's of course stuff that we're doing right now.
And to bring it back to that fire that you mentioned around here in LA, the dropping the water
Yeah,
plane, that's more of the targeted, but then the myeloid response would be the firefighters right there on the
exactly.
front trying to create the barrier. I mean, that I can see that.
It's
I mean, I
exactly the
see
same.
it.
Right, exactly. Getting maybe the individual house fires, the small stuff that's there. The big stuff, the bigger ones have been knocked out by the planes, and yeah, they're going getting the rest of the small ones and put it all out.
So the synergy is through the delivery, it's through the penetration, the distribution, the immune recognition, processing, and remodeling the tumor microenvironment, and all of that is activating this abscopal effect. Now, we're not just activating an acute innate immune response, but we're also recruiting and activating the adaptive immune response, right? Because I mean, people go, okay, destroy the tumor. Yes, that's that acute local,
Yeah,
which we want, but we also want this to be a time and spatial where it's also outside the tumor and it's long term.
yeah, and that gives a memory and it gives a long term cures, right? Yeah,
Yeah.
so
So it's really, it's like people go, well, I had the flu. No, well, let me back up. That's not a great one. I had chicken pox.
well,
Okay.
the flu though, obviously because it's different versions, right? And
Yeah.
so
That's what's chicken pox. So
yeah,
I got chicken pox. Okay. So you've activated the immune system.
yeah,
So you're going to have sustained
right,
memory, immune memory.
yeah,
So that if that virus ever tries to reactivate again, we know that those patients have less issue with shingles later in life. But if they don't get exposed and then they get exposed later in life, they don't have that immunity, that defense, that
right,
long-term memory, boom, shingles becomes quite abrupt and aggressive.
right, exactly.
So it really it's there. And so it's not just a time, but it's also a spatial thing where it's local and it's distant, it's acute, and it's long term, but it's because we're activating the immune system. We're priming the
Mhm.
body's defense.
Yeah, yeah, creating essentially a vaccine against that cancer. So
Yeah.
you're treating it simultaneously. You're getting rid of it, but you're also vaccinating the body against it. So should there be like I mean, technically, what you see, I mean, of course, like this in the mouse models is that once you cure the mouse of that cancer, you try to give it back to them. They don't get it. So yeah, and so that means that in humans, and particularly what you would see is crossover type cancers. For example, let's say you treated a BRCA related breast cancer. Um, Probably the patient getting a BRCA related ovarian cancer would be less likely at that point. If you treated a KRAS mutated pancreatic cancer, then a future KRAS mutated colorectal cancer probably less likely. So, yeah. so
So
so they have like this protection against other cancers that would be of similar relation.
that's a good point because I was having a discussion with a friend the other day about the word vaccination and what it means. It's interestingly enough, the word, the origin of the word Latin means pertaining to cows. I don't think most people, they're like vaccination. It's like, oh, what? How's that relate to a cow?
Yeah,
But the point here is it's about prevention. So when you talk about cancer vaccine here, it's about prevention. You're talking about prevention recurrence, prevention in secondary tumors. And so by activating that immune system, you are working preventatively while you target the tumor.
yeah,
So it's really kind of and I think this is one of the challenges that we have in the arena of cancer care is there's too much sequential thinking,
yeah, yeah,
too one dimensional. Cancer is like quantum physics. And we're like down here just doing basic calculations,
exactly.
and I think that's what you've been able to provide, Jason, is this ability to just say, no, I'm not limiting my thoughts here. It's like, let's just open it all up.
Yeah, yeah.
Let's just open it all up. Now,
Yeah, I think that's in the difference. You see with the immunotherapy versus the older treatments of chemotherapy is immunotherapy will make you healthier and would theoretically prevent future cancers, whereas chemotherapy is more likely to give you future cancers. so
well,
that's
that and radiation. I mean, it's
yeah,
in the
radiation,
literature. It's there.
right?
Uh, and everybody recognizes it, and there's always work to prevent it. So it's not like we're saying something that's not existent in the literature.
Yeah, exactly.
And so then people will often ask, well, where's the research? What's the studies, the evidence that supports this combination, this synergistic approach of intratumoral ablation and intratumoral immunotherapy? And that's a valid question. And we have to understand that in all science, as it relates to medicine, there are limiting factors, but we don't have a lot of limiting factors here because there's actually tons of preclinical studies, particularly animal models.
Great. Yeah, great data. I mean, I think that the data is overwhelming. It's just surprising how often we see this stuff where they do this amazing animal data. Like, oh, look at this, we did this, and then nobody does anything with it. But obviously we have, and we have, of course, the support of that, and now we have more and more human data coming out, and now there's more clinical trials, and so the movement is happening, right? It's there. And I think we're definitely picking up a lot of momentum, and I think we're going to see changes happen more rapidly. I think we had this, long time of a buildup that was really slow, and it seemed like not much was happening, at least from other people doing it. And now I think it'll be catching on.
Yeah, and clearly, experience in terms of outcomes, they're speaking for themselves, and patients do the best of sharing their experience. Because as we've mentioned before, that one of the things is the targeting of the tumor, which is amazing, but it's the quality of life.
Yeah.
Because the standard right now is go through treatment, let's hope you make it, then let's work on recovery, then start to live.
Yeah.
Our patients, they don't stop living. And in fact, I would say they actually begin living anew with treatment.
Yeah, I mean, this makes them all, better and healthier in the end. I mean, obviously there can be some rough goes depending on the situation. Again, our biggest challenge is, if we got patients from fresh diagnosis, then that would be easy, and I think the patient would do really well. But that's not what we get. We get patients who've had all these problems, and now, they have tubes and stents and stuff. Their anatomy's been reworked. They're not the same. They've been treated with chemotherapies. Their immune system's weakened. They've had all these other issues, and now we get them as patients. So, and a lot of times we're dealing with those type of problems, or the issues that causes, and it certainly impedes our treatment. So, in the future, hopefully we get more and more people straight out of their first diagnosis and not, waiting until their end of line, which is what we end up seeing the most part now. And I understand it because, like, the patients have the illusion, I have cancer, I'm going to go to my standard place, MD Anderson, Sloan Kettering, whoever, great cancer centers, and they're going to cure me. And first they have that illusion in a particular stage 4 patient, right? And then eventually that illusion starts to crash and then they realize, and then the reality hits. And at that point is when they start looking for other options. And that's when people would end up finding us. And so it's unfortunate that it's not sooner. But the thing is that, obviously we want other centers doing what we're doing. I mean, we want MD Anderson, we want Sloan Kettering, all those to do what we do. Cause we just want to help people. Unfortunately at this time, nobody, even people who might say that they do that we do, nobody does what we do because they don't have the same drug options. We have far more advanced capabilities. It's unfortunate. I wish other people did, and they may say it, but they don't. And so, but in the future, hopefully they will, and we'll be happy to help them. So, we'll see, but we just want to change, cancer care better for everybody.
And on that note, people go, what do you mean all these tubes and everything? You've talked about, at least we've had private conversations about how in pancreatic cancer, if there's a biliary stent in place,
and
liver mets, the difference between the two in terms of outcome, that's with or without a biliary stent, night and day difference.
It's a big difference. Yeah, I mean, like I see these cases, and a lot of times, like, patient's got a biliary stent. Well, I think I can help them, but it's one, like, you wish they just didn't have that. I mean, because they're going to have a lot more problems. There are patients with heavy bowel resections, or patients with, you see them where they removed their spleen, they've done all sorts of stuff to them. The patient's is not they just don't have their body parts. They don't have things that they need. Spleen, probably you need it for a reason. I mean, actually, most of our body parts, I think we need for a reason, and we probably shouldn't be taking any of them out. And that's, but yeah, it's unfortunate.
And I wonder if that, if the stents, clearly it's a foreign body.
Yeah,
The body is obviously something where, bacteria, biofilms, viromes, microbiomes, all these foreign agents, if you will, that are collected within tumors, if that is also playing a role in propagating the progression and immune evasion of those tumors where these foreign bodies are implanted. And you see this, like, for example, in breast cancer where they've got those markers in there, right?
yeah, right, yeah.
You continue to see these often hot spots around those markers.
Yeah.
It's like, well, if you got a tumor and it's described as a tumor that doesn't heal, a wound that does not heal, excuse me, and then you put a foreign body in it, what would you expect?
Yeah.
Aggravation, inflammatory response in that environment that's already abnormal.
Yeah, the body doesn't like these foreign things in it.
It likes its parts, as you said, and it doesn't like foreign parts added to it.
Yeah.
So, and studies have actually shown this to also be safe. So the synergy here is actually the two together are exponentially beneficial. Mm-hmm. Safe in human studies. Again, that cryoablation and the immunotherapy checkpoint inhibitor shown to be safe and effective, the combination rather than each individually alone. So now our job is to continue to help more patients, Jason, but also to spread the word and grow the number of doctors and practices that are actually helping more patients in not an escalating way, but a de-escalating way.
Yeah, exactly.
And it's through innovation and really your mind, because there's more to come, is there not?
Definitely.
Innovation never stops.
That's right.
Well, Jason, thanks for joining us here. I thought it was a great opportunity to bring to the front a common question patients will get. A recent patient from South Korea that will be joining us soon. But I thought let's tackle this and let's go through some specific points. And of course, always, if you want to learn more, check out the show notes. You'll see all the studies supporting it, and you can dive as deep as you want to. Thanks again, Jason. I look forward to seeing where the new innovations come, and we will see you on the next podcast.
Thanks for joining us on this episode of the Prescribe Podcast. All references supporting this episode can be found on the prescribe.com website. That's pre-scribe.com. To get your next dose of medical innovation, make sure you subscribe to Prescribe. We'll see you for your next refill.